and welcome to the topic Hemolytic diseases in the Hematology module. By the end of this topic, you should be able to define hemolytic diseases, discuss the pathophysiology and causes, understand the clinical manifestations of hemolytic diseases, discuss the management approach, and discuss the complications of these diseases. Let's get started. Hemolytic anemia is a form of anemia due to hemolysis, the abnormal breakdown of red blood cells either in the blood vessels, which is known as intravascular, or elsewhere in the human body known as extravascular. Hemolysis can be due to hereditary and acquired disorders. The etiology of premature erythrocyte destruction is diverse and can be due to conditions such as intrinsic membrane defects, abnormal hemoglobins, erythrocyte enzymatic defects, immune destruction to erythrocytes, mechanical injury, and hypersplenism. Hereditary disorders may cause hemolysis as a result of erythrocyte membrane abnormalities, enzymatic defects, and hemoglobin abnormalities. And examples include glucose 6-phosphate dehydrogenase deficiency, or also known as G6PD deficiency, hereditary spherocytosis, and sickle cell anemia. Acquired causes of hemolysis include immune disorders, toxic chemicals and drugs, antiviral agents such as ribavirin, and physical damage and infections. Hemolysis may be an extravascular or an intravascular phenomenon. Autoimmune hemolytic anemia and hereditary spherocytosis are examples of extravascular hemolysis because the red blood cells are destroyed in the spleen and other reticuloendothelial tissues. In intravascular hemolysis, it occurs in hemolytic anemia due to the following examples such as prostatic cardiac valves, G6PD deficiency, thrombotic thrombocytopenic purpura, also known as TTP, disseminated intravascular coagulation or DIVC, transfusion of ABO-incompatible blood, and paroxysmal nocturnal hemoglobinuria. Now, let's take a look at the signs and symptoms that one would expect to see in hemolytic diseases. So as for intravascular hemolysis, of course, there would be signs of anemia as the red blood cells are all broken down. There would be tachycardia, dyspnea, angina, weakness. There can be leg ulcers, bilirubin gallstones, and abdominal pain. In hemosiderosis, you may also encounter signs of iron overload such as bronze skin color and diabetes. In hemoglobinuria, you would expect to see dark colored urine. And in thrombotic thrombocytopenic purpura or TTP, there might be some additional signs such as neurological manifestations, renal failure, thrombocytopenia, apart from venous thromboembolism. Jaundice may occur because of a modest increase in indirect bilirubin hemolysis. Jaundice occur because of a modest increase in indirect bilirubin in hemolysis. Splenomegaly occurs in hereditary spherocytosis and other hemolytic anemias. Butterfly, malar rash, and arthritis is seen in autoimmune-related diseases. Right upper abdominal quadrant tenderness may indicate cholelithiasis. Angina and heart failure symptoms as well as pale conjunctiva and fingernails indicate anemia. Among the lab studies that can be carried out include the standard blood studies, which include full blood count, peripheral blood smear, serum lactate dehydrogenase or LDH, serum haptoglobin, and indirect bilirubin. And as for the specific studies, you want to look at direct antiglobulin test or DAT, urine-free hemoglobin test, urine hemosiderin test, red blood cell survival test, which is quite rarely done, cold agglutinin titer, G6PD screen, and sickle cell screen. So the changes in the LDH and serum haptoglobin levels are the most sensitive general tests because the indirect bilirubin is not always increased. An ultrasound is used to estimate the spleen size. Since the physical exam occasionally does not detect significant splenomegaly, you may also carry out other tests such as a chest radiograph and ECG, and this is to evaluate the cardiopulmonary status. As for treatment and management, transfusion therapy should be avoided unless absolutely necessary. Erythropoietin or EPO therapy is sometimes given to reduce transfusion requirements. Discontinuing medications, and this may include penicillin and other agents that can cause immune hemolysis, and this should be discontinued. Iron therapy, splenectomy is the first choice of treatment in hereditary spherocytosis. And as for long-term monitoring, monitor the hemoglobin level, reticulocyte level, indirect bilirubin values, LDH level, and haptoglobin values. Other treatments include folic acid, which should be recommended for patients with ongoing hemolysis, Administer oral iron to patients who have become iron deficient due to the intravascular hemolysis. And one should taper corticosteroids. Occasionally, patients may have to continue low-dose steroids. As mentioned earlier, when it comes to surgery, splenectomy may be the first choice of treatment in some types of hemolytic anemia, such as hereditary spherocytosis and autoimmune hemolytic anemia. Splenectomy is usually not recommended in hemolytic diseases that's intravascular, such as cold agglutinin hemolytic anemia. The prognosis for patients with hemolytic anemia depends on the underlying cause, and overall mortality rates are low. The risk is greater in older patients and patients with cardiovascular impairment, and the morbidity depends on the etiology of the hemolysis as well as the underlying disorders such as sickle cell anemia or malaria. We have looked at hemolytic diseases, which is anemia due to hemolysis, and this can be divided into intravascular and extravascular hemolytic anemia. We have looked at the pathophysiology and the causes, the common signs and symptoms that we expect to see if there's hemolysis, which is jaundice, as well as anemia. The common lab tests and imaging studies that are carried out not only to diagnose but to also assess the severity of the disease. The mode of treatment, which also includes medical and surgical approach of therapy. And finally, the prognosis of hemolytic diseases. We have come to the end of this topic. Thank you.